Good afternoon. This talk is, I'm talking about how we can use in indocyanine green infrared imaging in our outpatient clinic. So I'd like to know how many lymphedema therapists in the audience? Can you raise in hand? Lots of the people. It's very good. So this talk is mainly talking about how we can improve in conservative management. So then the Macquarie University, we provide in educational course for training lymphedema therapists. I used to ask to give in anatomy talk, and then last year I sit in a 9-day course for learning as a lymphedema therapist, and then so I've seen a lot of the controversy. So what I seen it and then what I learning from the current conservative, the textbook of the conservative management. So then the alert clinic, so then we have been running 3 different clinics. The conservative clinic and then diagnostic clinic and then surgical clinic. So then I operating in the 2 clinic, the diagnostic clinic and the surgical clinic. I operate in indocyanine green infrared imaging. So the people may think the infrared imaging for something new technology, but it's quite old technology. Already 1960s, so the eye doctor already used for the vascular analysis in the same technology. So you can see that it's quite old type of the commercialized machine, already being available in the 1960s. So then Japanese the breast oncologic group, and then start to consider the technology can be applicable for breast sentinel lymph node biopsy. So then this is a prototype of the machine, and then they injected the indocyanine green in the subareolar plexus. So as I introduced in my first talk, so the lymphatic vessel is is running towards the armpit, and then so we can just trace in the lymphatic vessel towards the armpit, and then making a small skin incision. So sentinel lymph node is lights up. So this is probably the first application of the lymphatic application for the infrared imaging. So then vascular surgeon is considered. So it might be used for the lymphedema diagnosis. So the difference between the vascular and the lymphatic is pretty easy. But for the vascular, injecting into the intravenously, for the lymphatic, injecting the intradermal or subcutaneous. So this is a patient of the secondary lymphedema. So the lymphoscintigraphy image is the dermal backflow is shown like this, indocyanine green image showing a similar picture. So then plastic group in Japan, Professor Isao Koshima, can be synced. So this mapping could be useful for the lymphovenous anastomosis. So lymphovenous anastomosis already started in the 1970s. But the difficult part is to identify, locating a lymphatic vessel. But using this machine, so can map the lymphatic vessel prior to the surgery. So then afterwards, so this technology is spread in a plastic surgery department. So then after I learning from the Japanese group, so I working with together with Professor David Chan. Currently, is in the University of Chicago. So we installing infrared imaging to the UTMD Anderson. So then over the 7 years period, so I assisted more than 250 cases of the lymphovenous anastomosis. So as I've shown before, so the amount of the dermal backflow, amount of the remaining lymphatic channel is quite correlated with the severity of the lymphedema. So the amount of the lymphatic vessel reducing, so the lymphedema gets more severe. So then I created a staging system. So back to the anatomy. So anatomy is quite important. Normal anatomy is quite important to read in indocyanine green images, because without knowing the normal anatomy, hard to understand what kind of the changes occur in a lymphedema patient. So then, fortunately, the indocyanine green also working in fresh human cadavers. So that I collaborated with a Japanese group and then publishing this kind of the information. So this is currently our protocol. We're using a machine in our outpatient clinic. So we injected a 4th spot in this circumferentially based on my anatomical knowledge. And then because of multiple injection, it could be painful. So then we are using a cryogenic numbing device just before the injection applied, and then making the skin with a cold numbness to reducing the needle discomfort. So then initial observation takes about 10 to 20 minutes to see how the initial get some initial idea how the patient lymphatic condition is. And then, so the lymphedema therapist join the examination and then start to apply the manual lymphatic drainage to the 30 to 60 minutes. And then finally, just collecting all of the imaging data. So this is our current protocol. So then I just showing what we find in our clinic. So there is a couple of the different pattern we've seen in our patient is a breast cancer-related lymphedema. So the lymphatic is incining ring extended to the same side of the armpit or clavicular region or parasternal region, or coming to the dermal buccal, extend to the front of the chest, and then crossing the midline, and then switch to the normal lymphatic channel in the contralateral side of the chest, and then drain to the contralateral armpit. So these are the patient. I just put the color on the dermal buccal area. So the dermal buccal is not entirely cover the arm, and then just only the cover the part of the arm, and then but the condition gets severe, so it's going to be more extensive, and then even extended to the front of the chest. So this is a schematic diagram. So after the actually no dissection and the mastectomy, so either going to the armpit or going to the clavicular region or parasternal region, or extended to the midline and then switch to the normal lymphatic vessel in the other side of the chest. So I just showing each cases together with a video. So this is a patient. So this is we can see the breast cancer related, all the breast cancer patients. So the dermal buccal showing the medial side of the elbow. So that's definitely is categorized as a lymphedema. But in the proximal area in the upper arm, so switch to the one vessel. So that vessel extend to the armpit. So you can see the dimple in the axillary area. So that she had all axillary dissection. So this vessel is applied a massage. It's going to be drained, extended towards the ipsilateral axillary region. So this is a pattern to the going to the ipsilateral axillary region. So this is a second pattern. So the dermal buccal is a little bit more extensive, and then cover the medial side of the elbow. And then medial side vessel is stopped, and then this vessel is show up. So this vessel is running, coming to the in front of the shoulder, and then so show up the interval lymph node. So this is a deltopectoral lymph node. And then effluent vessel of the deltopectoral lymph node is running behind the pectus major muscle, and then missing the signal temporarily. But so see the clavicular region. So this is a second pattern. So this is a pattern to extend to the front chest. So the dermal buccal is come over the shoulder, it leads to the in front of the chest. And then so apply the manual lymphatic drainage. So the inside in green moving towards the midline. And then you can see switch to the normal lymphatic vessel in the contralateral side, and then drain to the contralateral axillary region. So that is a front, and then so like this way. So Then we applied this one for since February 2017 to the April 2018. So then 14 months. So we scanned 113 patients, including the 4 bilateral patients. So the total number of the arm we scanning is 170. So interestingly, so the 7 patients is the diagnosis of lymphedema in the other hospital, but actually there is no symptom of the lymphedema. So might be a little bit mixed up with some of the nerve sensation damage. So the arm lymphedema is detected by the 110 cases, and then most of the cause of the lymphedema is a breast cancer in our population. So the other melanoma and the sarcoma are a few cases. So we extracted our 103 cases of the breast cancer-related lymphedema. And then, so the actual surgery is most of the cases, as a majority of the cases are actually no dissection. So the sentinel node biopsy cases are only the 2 cases, and then people cannot remember what kind of the procedure are the 2 cases. It seems to be that definitely the sentinel lymph node biopsy having a preventive effect for developing the lymphedema. As for the drainage lesion we detected, is a 67% of the patient. So even having actually no dissection, still drain to the ipsilateral axilla. And then 41% is going to the clavicular region, and then 8% going to the parasternal region, and then 5% going to the contralateral axillary region, and then none of the patients going to the inguinal region. So there is an overlap. So that's why the sum up the number is over the 100%. And then this table, we just divided by the severity and also the drainage lesion. So I'm using the MD Anderson staging. So the 1, 2, 3, 4, it's basically the number is increasing. Its severity is going to increasing. And then, so almost all group, still the majority of the patient is drained to the ipsilateral axilla. And then, so the patient going to having the clavicular pathway is a 2 or 3 group, and then the severity a little bit increased, and then more chance to go into the clavicular region. And then, so in the severe cases, more prone to the going to the by the front lesion is going to the parasternal or contralateral lesion. And then again, so none of the patients show up to the going to the ipsilateral inguinal region. So then ICG application, think about how the ICG can be utilized for the personalized care. So clinical implication of the management is, so then this is, I guess, the big take-home message. Actual surgery doesn't always block the lymphatic pathway. Even the patient having the actual node dissection, still the drainage pathway, the actual area. And then, so for the lymphatic surgery, so that we can specify that which pathway is currently working. And also, we can see the blockage point of the where the lymphatic vessels stop and then start to show up the dermal backflow. So currently, we're using this information for the lymphovenous anastomosis because there is no guarantee for the long-term patency of the lymphovenous anastomosis. So that's why we've seen any of the working pathway, we just avoid to touching these vessels. Because if I apply these vessels, there is a chance to be the knockdown these currently working pathway. As for the conservative management, and so the manual lymphatic drainage technique can be modified. If we see the lymphatic vessel, so we can apply the gentle and the fast massages could be enough to move in the congestive fluid. But if the dermal backflow is shown, so need a little bit firm and also the very slow massage. So this is a current status of the manual lymphatic drainage in the literature review. So the effectiveness of the, So the effectiveness of the manual lymphatic drainage is inconclusive. So some literature said it's positive, some are negative. The Cochrane review in 2015. So this report said, so there is no effective for the prevention of the lymphedema. So that could be the negative the information. But there's another Cochrane review showing the MLD is generally regarded as safe as an adjunct to the complex lymphedema therapy in the mild and moderate lymphedema is a positive information. So then we have found that so the enzyme in green has improved, could be improving the effectiveness of the MLD because we can find in the individual pathways. So I just show in the few video how we can possibly modify our MLD technique. So this is a patient in a mild lymphedema. Still can see lots of the remaining lymphatic channels, and then Dharma backflow is also showing. So even just applying one single finger massage is the gentle massage. So the inside in green moving through the lymphatic channel. So it's pretty easy. So actually we can see how the massage can shift in the fluid by using the indocyanine green machine. But if the patient gets in a more severe condition, like a Dharma backflow is extensively cover the arm, and then this time, so need a more slow massage and then a little bit firm massage going to be needed to shifting the fluid. So like you can see in front of the finger, so like a more fluid is extending. So if the gentle massage applied to the Dharma backflow area, so it's not shifting at all. And then once so crossing that watershed area, just going to the next lymphosome territory, so then shifting to the remaining lymphatic channel and then drain to the neck lymph node in this patient. So then this kind of the information we are going to feed back to our patient and also the therapist. So then usefulness of the inside in green for the outpatient clinic could be that we can identify the congested area. So its Dharma backflow is not uniformly cover the arm. So there is a demarcation. So then we can specify where the congested area. And also, so direction to how to shifting these congestive fluid. So the arrow is showing where to move. And then, so this can be making like a personalized navigation of the MLD, like a navigating system. So this is the thing. So as for the personalized manual lymphatic drainage, including so the different hand pressure for the vessel and the area of the Dharma backflow. As for the vessel remaining, so the gentle massage and is enough. And then different hand speed for the vessel and the area of the Dharma backflow. So if the vessel remaining, first massage may be enough, but it's having the Dharma backflow area, need a really, really slow massage. The reason is probably the caliber of the lymphatic vessel is much, much smaller. So then identification of the drainage pathway. So in summary, so the inside lymphography started as the imaging tool for the vascular analysis. So currently, still the downside is off-label use because the dye itself hasn't had a official application for the lymphedema diagnosis. But now there are lots of the people and the doctor and the company working on to expand in the application for the inside dye for the lymphedema diagnosis. And the way of the lymph drain, so always the anatomy is altered and then drainage pathway is changed in the normal condition. So may impact on the lymphedema severity. such as the person having a drainage pathway to the contralateral armpit, so could be the more severe the group of the patient. And then identifying the drainage pathway and also the area of the congestion allow us to personalize lymphedema management and the care. So thank you very much for your attention.